Thank you, Chris. Whenever I hear people saying they need a nurse practitioner model, I get a little excited about that. So being an oncology nurse practitioner, delighted to hear that's going to be your next step. So let's move forward with those sort of ideas, the equity-based care. We know disparities exist. Thinking about really that community focus. Our next speaker is Sarah Wu. She's a social worker and the Massachusetts General Hospital Director of Community Health Improvement in Chelsea, Massachusetts. Her work is focused on the poor and underserved and refugee populations. And her talk today is going to be about improving health in diverse communities. Sarah?
Thank you very much, and thank you for inviting me to speak. It's a real honor to be here. So I'm a little bit more of a storyteller, a little bit less less of slides. I'm going to start with pictures. So I could not do this work without my cancer navigation team. So this is the biggest thanks to and actually I think some of them may be watching by webcast. So shout out to everyone in Chelsea who's watching. Hopefully some of them are today. But this is the current team of cancer navigators that I have in Chelsea. And I just want to say a special thank you. Several of you will recognize some of the names in the room, the names here on this slide. I'm a doer. I'm not a researcher. So this is the group that taught me that it's really important to research because we need to have results. And these are the people who showed us how to do randomized control trials and prove that our work actually does work and has results. So just a real shout out to them as well. So this is Chelsea. Chelsea is a very poor, so you've heard a lot about Boston. So Chelsea is north of Boston, literally just right over the bridge. It's a predominantly Latino community. It's incredibly poor. It's the most dangerous city in the state of Massachusetts. So, and it's got the highest child abuse and neglect rates. So it's a very, very poor, underserved community, but it's tiny. It's 2 square miles, that's it. And, you know, it's just very, very urban. And people say, oh, it's on the water. Well, this is what we look, it is actually on the water, but this is what the Chelsea Creek looks like. So it's very, very poor. So Chelsea's always been a gateway community. It's a gateway community. We have many folks who come up from Central America. We have refugees who come from Nepal, Bosnia, Somalia, Afghanistan, Iraq, Syria, Northern and Western Africa, and these are some more of my staff. What I try and do, and I've actually been working in Chelsea for 20 years, and I started as a community health worker myself. So I worked in Harlem as a community health worker when I was getting my master's in social work at Columbia, and just have sort of, I believe in community health work, like everything about it. So I, have done this work and have just had the pleasure of building a team over the years. So you'll see, I actually have quite a big team in Chelsea, and you'll see, but it's taken 20 years to build it. So we've come a long way. But MGH is, you've heard about the wonderful academic medical partnerships that Mass General has. And I think what's really fantastic is that MGH has, within the past few years, changed their mission statement. So we not only aim to do sort of quality patient care, teaching, and research, which is similar to all the other academic medical centers in the whole country, but we really did include taking care of the rich and diverse communities that we serve. So the community health is right up in the mission of Mass General Hospital's mission statement, which helps us to kind of lend credibility to the work and really gives us a lot of impetus to do this work. So yes, I have 45 community health workers. I'm super lucky. I can't even tell you how lucky I am. That comes from multitude of funding sources. Some of them are directly from the hospital funding. We've sort of created positions over time. We've proved them effective. And then the hospital has turned around and supported them with their dollars. We also have funding that comes from grateful patients. We have funding that comes from different foundations, Department of Public Health in Massachusetts, just many, many, many different sources. But what's exciting about the team in Chelsea is that the team comes from 25 different countries and we speak 21 different languages. So we're really working overall on accessing hospital services. Again, Chelsea's just over the bridge, but it's like years away for someone who doesn't know how to get down to Mass General Hospital. It seems so see, like we can almost see Mass General Hospital, but it's like the transportation doesn't work well, and if you don't speak the language and whatever. So we're looking overall at managing chronic diseases. We're looking at medication adherence. We're looking at navigating patients not only to cancer care and cancer like screenings, but we've actually really verged into sort of what are all the specialty appointments that patients need help navigating. So I have community health workers and patient navigators, so just to kind of differentiate. And we're really working in all of our programs with patients who have a history of trauma, who have extreme poverty, isolation, low literacy, language barriers, and many social determinants of health. So this is the team. It's a fabulous team. But what I wanted to show you this slide because over time, everyone on this team knows how to navigate patients for cancer care. So one of the things that we really feel strongly about is cross-training, and we have very clear systems of manuals and kind of protocols. So even folks who are working as early childhood home visitors, for example, if their patient is dealing with, an overdue cancer, like a mammogram screening, they're the ones who actually, put on the navigator hat and actually help their patient to do it. So we heard earlier that, it gets confusing when one patient has like 8 different people working with them. It was just from the last session. And what we really try and do here is to say, okay, there's going to be one primary person working with the patient, and yet, if they don't feel 100% confident, they can ask their colleagues and sort of get advice as to how to do that, but that one person is really the direct face with the patient. So we've talked in earlier sessions that community health workers do often have shared life experience. So what we try and do in Chelsea is to really match patients with someone from their same culture. So because we have so many staff, we really do look to, someone's from Somalia, let's match them up with a Somali community health worker. And so we're working on cultural mediation, culturally appropriate health education, care coordination, case management, system navigation. We provide coaching and social support, advocating, providing direct care, and really building capacity for patients to care for their own health. So this is similar to what I've just said, but it's these are the sort of domains that we work, sort of patient advocacy. We're looking at really building skills and looking at patients' rights. In health education, we're looking at health promotion, disease prevention, treatment and control. Outreach, we're looking at patient-centered planning. So, the provider has X, Y, or Z goal, and we're really looking at what does that goal mean for that patient. And sometimes there's really a disconnect there. We had an elderly Nepali woman, for example, who was losing her eyesight, and everybody wanted her to have cataract surgery. She didn't want the cataract surgery. So it's like she was fine. She had caretakers at home. She had her daughter and her son stayed with her. It was just not where she was. So a lot of times community health workers or navigators actually have to bridge the disconnect between where the patient is and where the provider is, and to really be the advocate for the patient, because the patient's voice is important. And just to sort of speak a little bit more to that. So we saw many of our patients have histories of trauma. So they're coming from war-torn countries, or they've got refugee experiences or domestic violence, or whatever it is, whatever all the multitudes of trauma are that we all experience. Making sure that the patient has a voice is critical. As soon as we start to take away the patient's voice, we're re-traumatizing them again, even if we think it's the right thing. Like we really think that this colonoscopy is really what they need to do now, but it's their decision. So it's like, let's keep the doors open. Let's kind of continue to talk to them and really continue our work in a trauma-informed way that continues to have the patient's voice front and center. And then obviously health systems navigation is, accessing appointments. So again, this is what I just said. We really work on what's the provider's goal. We match them with the patient's goal, and that's where the community health worker comes in. And the whole point of the work is to really build patient self-efficacy and build their confidence in their own, taking care of their own health. So for example, if I'm able to achieve one small health goal, then you set another goal with me, and I'll be able to maybe achieve that, and then achieve the next, and then the next. And so meanwhile, like I'm learning how to take care of my own health. So every time a patient navigator goes with a patient to an appointment in Boston, for example, at the main campus at MGH, That's where all the treatment is happening. All the way along the line, they're teaching a patient. You see, this is where you go first, this is where you go second, and then here's the information desk, and then you walk down this hallway. It's like really, it's a whole guiding and teaching so that the patient feels comfortable that they can do it on the next time on their own. So patient navigation in Chelsea has been going on for a while, and it actually didn't start with a disparities focus. And so as I sort of thought about what to talk about today, we actually do have a wide range of cancer navigation programs. So it's just hard to kind of know exactly what to focus on. But we started actually looking at in 2001. We've actually worked directly with over 1,600 patients at this point in time. And we're working on breast, cervical, colorectal. We've done some lung cancer work and are now working with patients who have any kind of cancer or any kind of specialty that's trying to rule out a cancer navigation. Yeah. So we started in 2001 with funding from Avon, actually, and the mammogram rates in Chelsea are quite high. So this was not a disparities-based program. But what we said is, okay, well, the population in Chelsea is an underserved population, so let's just start there. And so what we tried to do is to kind of get patients in for their appointments, within 60 days or less, follow-up appointments, and we created what was called one-stop shopping. So if a Chelsea patient is referred by their primary care physician on a Monday, they go in for an appointment. There's an abnormal finding, like a lump that's found in the physician's office. On that Thursday, they could be at the Avon Breast Center in Boston, and they could see the oncologist, they could see the radiologist. There would be a Spanish interpreter there. So it's like they get everything all at once. So it made that sort of trip over to Boston easier, that they didn't have to keep going, that we could kind of get them where they were. So we tried to kind of make navigation as easy as possible for folks. And we've worked with quite a few patients, and we're now actually helping patients not only in Chelsea, but in all of the other surrounding communities, which are the North Shore of Boston, so Revere, Charlestown, Everett, for anyone who knows the area. So so that was sort of the beginning, and then we actually looked at data that did show a significant disparity. So in 2005, primary care patients across the whole system at Mass General, the colorectal cancer screening between Latino patients and white patients, there was a significant disparity that we found, and so data actually showed that. So out of all of Mass General, Chelsea had the lowest colorectal cancer screening rates, and there was a significant disparity between Latino patients and white patients. So in 2007, we actually started, the colorectal cancer screening program, and actually we're able to kind of do a huge piece of work. We hired a full-time Latina navigator at that time, because that's where the disparity was. And she, it was a randomized controlled trial. She reached out to patients, got them the screening that they needed, helped them to get there, broke down all the barriers, looked at language, transportation, low literacy, lack of supports, the inability to take time off, all the fear that came up for patients. The lack of understanding around the importance of screening. Again, patients who are newly arrived may have had very different experiences with healthcare systems. And so kind of why is screening important? Why do I need to do this? And sort of all the cultural beliefs around cancer. And again, colorectal cancer screening is not someone's top priority if they've got, housing issues and hunger issues and violence in their, it's very, very hard. So we knew that we had to really put a big piece of effort if we were going to try and tackle this disparity. And we actually did. We actually did tackle this disparity. Sort of, you can see over time that the Latino patients, in fact, over time have even a better colorectal cancer screening rate than white patients in Chelsea. So that was exciting. And then in terms of kind of bringing MGH Chelsea up to the level of all the rest of the MGH practices. So again, as I sort of showed you this great team of people over, at the very beginning, so every single one of those people know how to navigate people for colorectal cancer screening. So one of the reasons why this went up is because there's actually a gentleman who speaks Arabic and Dari on my team, and so he sort of took some extra training around colon cancer screening. There's another young woman who speaks Bosnian. She took some extra training, and then another young woman who speaks Arabic and Somali. So she took some extra training. So it's almost like we had a full-time Latina navigator, and then we had adjunct navigators who spoke other languages. They had other jobs too. They were working on diabetes and high blood pressure, and et cetera, but they were really, really good at colorectal cancer screening as well. So these are some of the navigators. And I'll just highlight one other project, because again, I think this is somewhat unique for Chelsea. So through the funds that we got from Avon, we actually were looking at specifically refugee women and looking at the screening rates. And so we looked particularly here at refugees who had recently come over from Somalia, Bosnia, and then Arabic-speaking women from both the Middle East and from Africa. And we actually, so these are self-identified women, and we enrolled them in this study, in April 2009. And what we did was we each group was very different, and just to kind of highlight that, so you kind of go into a program and you say, okay, well, we just did this, this program for Latino women, and we knew what worked there. What can we learn and bring over to these new populations? They're all completely different. So, really go out and ask the population, do focus groups and interviews to see what would work. We actually found that the Somali women, in our experience, this is not a generalization, but in our experience, Somali women were very, very comfortable meeting in groups and doing some sort of group health education sessions together, whereas the Bosnian women just wouldn't. It was a much more individual approach that we had to take. So even though this is one study, we had to do it in a very different way with each population. So, and then we tried to be just really creative about where we were going to reach people. So again, the Bosnian community was not comfortable meeting in groups in the health center or in the community, but we could reach them in the church. So for, sort of like, where could we go, where they naturally are and where they're naturally going, and how could we reach out to them? So we sent a letter to the patient, and then we used Navigators. Here again, we didn't have funding for a full-time navigator for each of these groups, so we used folks who had been medical interpreters, and trained them so that they were being medical interpreters for part of their time, and then navigators here. And I had mentioned earlier how important supervision is, and in this as well, sort of making sure that the navigators are very well supported, not only trained, but supported all the way along the line. So these three separate navigators who spoke three separate languages, had other jobs as well, but this is what they did for part of their time. So they actually would kind of call, and it really did a lot of exploring as to what cancer beliefs were. And in some cases, we really had to start at the very, very beginning about why is cancer important and why now we're living in this country. So we have access to these great academic medical centers. Let's make sure that we get the care that we need. We had to sort of frame it in a way of, you have all these relatives to take care of, make sure that your health is well, whatever worked kind of culturally and whatever was appropriate in terms of encouraging women to get their screenings done. And then, like I said, we did hold education sessions in the community. But when we sent any kind of materials, so many of the Somali patients that we worked with were illiterate, so sort of there's a lot of diagrams with pictures, and so it's very, very interesting. Each group was very different. And we were actually able to reduce the disparities around, mammogram screening. Again, the numbers are not as high as our white patients or our Latina patients in Chelsea, but we were able to make a difference. And these are just some more, so you can sort of see. So the refugee group is in purple. So it did actually come up quite a bit, but again, there's still a disparity there. So one thing here again is the initial funding is no more. So again, we wanted to sort of make sure that everybody who works with every population is trained and talking about, mammograms with their patients, so that we didn't want these numbers to go back down again. So every medical interpreter on the team, every person who's doing early childhood work, they're the ones who are actually helping their patients with their mammograms. So the limitations and challenges, I've already talked about some of them, but finding and keeping navigators, we've done a lot of thinking creatively about how to use medical interpreters as much as we could, how to sort of start out, someone who's a medical interpreter and train them to become, maybe first a patient navigator and then a more comprehensive community health worker. So finding and keeping navigators and really supporting them is a challenge. These were three very different ethnic groups with very different ideas around cancer and ideas around why, preventative care is important. And then the migrant populations, we sort of had known that from the Latina patients that we worked with, is that, they'd kind of come and go, and the turnover in the Chelsea public school system is unbelievable. Every single year, like there's huge populations that turn over because patients go back home and whatever. But one thing that we hadn't realized is that in the Bosnian population, everyone goes home for the summer. So it's like, sort of you start out and then everyone, like in the summer, you just can't reach anybody because they've all gone back to Croatia or Serbia or wherever they've come from. But that was certainly interesting. And then sort of working with, immigrants and refugees, there's all kinds of issues of trust, mistrust. These are all really, really tough genocidal community. So who can trust who? What works in terms of groups coming together? But the war trauma in these groups was really, really extreme. So just that was certainly a challenge to continue to be sensitive to that. So that's basically what I have. Thank you.
Thank you, Sarah. That was a great presentation and certainly another view of how we really need to culturally tailor our navigation programs for diverse populations.